We need to bend the cost curve in healthcare. Healthcare spending is unsustainable. We hear these terms all the time, but it's often difficult to figure out whose cost and whose spending are being discussed. This is important because somebody's cost is somebody else's income. The terms cost, spending, and expenditures are sometimes used interchangeably, but they should not be. I'm Thom Walsh. I'm one of the faculty members teaching at the Dartmouth Institute's Professional Education program. Let's define these terms more clearly and look at why clear definitions are so important. Healthcare spending is the amount spent by a payer to reimburse providers of healthcare services. Spending is sometimes referred to as societal costs, expenditures, reimbursement, or occasionally healthcare costs. But healthcare costs are the amount it takes to pay for the direct and indirect, fixed and variable items and time needed to deliver healthcare. These costs are sometimes referred to as charges or institutional costs. And to add to our confusion, they're sometimes called healthcare costs. Here's a quote to make the difference understandable. Spending on iPads is rising, but the cost of producing the tablets is not. And here's why it's important. Historically, healthcare spending has been rising. So have the costs. In fact, for most hospitals, the difference between their cost and a payer's spending is around 4 to 10%. This is referred to as an operating margin. Healthcare reform efforts help to create accountable care organizations. A central premise to an ACO is the idea of shared savings. If a hospital can bend its spending curve, a portion of the saved amount is shared back to the hospital. Successfully bending the spending curve is not without its risks. The red arrow indicates where payer spending drops below the cost of producing the healthcare services. While good for the country, this situation is not sustainable for the institution. Bending the spending curve, as required in an ACO arrangement, requires that an institution bend its cost curve sooner and more steeply than its spending curve bends. Now consider a spectrum of disease over a distribution or a sample taken from a population. More severe disease is to the right, less severe to the left. A portion of the population considered diseased increases as the threshold for a disease state moves to the left. On the one hand, this means more patients, but there's a subtle key point here. Lower thresholds also add more of the people who can improve the least. We consider the value of care as being defined as a patient's reported outcome divided by the cost of care to achieve the outcome. The potential for large changes in outcome lie to the right, closer to the more diseased state that we saw on the last slide. Here's another way to think of it. Moving toward the right on this figure, there are fewer very sick people. The green line shows the marginal benefit increases as we move to the right. Sicker people benefit more from the intervention to help them. But every intervention carries a risk. The slope of the risk line is not as steep as the benefit slope. So patients to the right of the risk-benefit intersection receive additional benefit, while patients to the left of the intersection can actually be harmed. We need to focus our efforts to reform healthcare delivery on the right-hand side of this slide. As this CBO report illustrated, even if you're focused in the correct area, you still must pay attention to the cost and spending. Disease management and care coordination efforts seek to improve the quality of care for patients who are very sick. A common focus is the reduction of hospital admissions or readmissions. The CBO report found few success stories from these innovative programs. The reason for the lack of success was most hospitals not understanding the differences between cost and spending. The programs they implemented had costs. Those costs were billed to Medicare appropriately. So while Medicare spending on readmissions was lowered, the added cost of the program meant There were fewer readmissions, but little to no total savings. To achieve savings in total spending, a new program's costs must be smaller than the reduction in spending it creates. Learn more about this topic, geographic variation in healthcare delivery, and ways to lower costs and spending, as well as increasing your patients' outcomes, by visiting us at tdiprofessionaleducation.org.